Welcome to our digital glaucoma support group. Thanks for joining. I hope you haven't had too much hassle with this blustery weather. I'm going to wait a minute, just another minute for more people to get signed in. Okay. Yeah. Okay. So welcome to everyone who's joined us. I'm Melanie Peters and I'm the Development Manager for Wales and Northern Ireland. Our speaker today is Dr. Harry Jayaram, Consultant Ophthalmic Surgeon from Moorfields Hospital, and he's going to talk about the different types of glaucoma in everything you ever wanted to know about glaucoma. So I'm delighted so many of you have chosen to spend this afternoon with us, and I'm just going to spend a few minutes talking about the format of today's talk, the technical side of Zoom, and who Glaucoma UK are. So just to go through some of the technicals of how this Zoom group works, we can't hear or see audience members, but you should be able to see and hear me and Harry. We're also being streamed live on Facebook, and if you're watching there, you can ask questions by commenting on the feed. There'll be 2 short polls launched during the webinar as well. And these are to help us see the difference the sessions are having and if you feel you're learning anything. I'm going to launch the first one now, and this will stay open for a few minutes. Okay. That should be up on your screen in a minute. Okay, if anybody would like to answer that poll, that would be great. Okay. If you're having technical difficulties, try turning off other devices which are connected to the Wi-Fi, or leaving the session and rejoining using the same link. Okay. I'm just going to launch that poll again because doesn't seem to be anything happening with that. Okay. Right. So if you'd like to ask a question, please wiggle your mouse or touch your screen and you'll see the Q&A option at the bottom of your screen. If you have any questions for me or Harry, just type them here. You can ask questions whenever, and we can see these throughout the session. Even if you don't have any questions, keep an eye on the Q&A panel. If you like a particular question, you can click like, and the most popular questions will come to the top of the list, and we'll try to answer those first. The chat button can be used if you're having any technical issues, but please keep your questions to our panelists in the Q&A section. It just makes it easier for us to keep things all in one place. We really want this session to be interactive and cover the topics you're most interested in. So please do ask any questions. The only silly question is the one you wanted to ask but didn't. We'll activate closed captioning during this talk. And if you want to switch them on, click on the button marked CC Live Transcript at the bottom right. This is automatic subtitling, which finds medical vocabulary hard. We've seen trabeculectomy turn to Rebecca said to me, and even trab turn to Trump. We're really interested in knowing a little bit about our audience joining us. So if you feel like it, please comment in the chat to tell us what brings you here today. So whether you have glaucoma, you have a child with glaucoma, or you work in glaucoma care and sight loss, and what you're hoping to learn from today's session. We want to make sure we provide information that's helpful to all of you. So the more information you share as an audience, the more likely we're going to be able to pitch the sessions right for you. So Glaucoma UK is the UK's charity for people with glaucoma, and we work in 3 main areas to prevent glaucoma sight loss. So firstly, we campaign to raise awareness of the disease. We want people to know what glaucoma is and about the importance of getting your eyes tested. The earlier glaucoma is diagnosed, the less likely people are to experience sight loss. Secondly, we provide support and advice to people with glaucoma and those who care for them. We have information leaflets, a helpline, a buddy service, a patient forum, and we provide training and advice to professionals looking after people with glaucoma. All of our services are free. And finally, we fund research into the diagnosis, treatment, care, and prevention of glaucoma. It's not a huge amount of money, but we often provide initial funding for seed research, and that gets early stage research going. So I'm going to hand over now to our speaker, Dr. Harry. Don't forget to post questions in the Q&A. And Harry, thank you ever so much. It's over to you.
Thanks, Mel. So my first challenge is to try and share my screen. So Mel, are my slides coming up okay?
Yes, yep, fine.
Okay, perfect. So this is probably the most challenging talk title that I've ever been given. Everything you ever wanted to know about glaucoma. Now would probably take about 2 or 3 years worth of webinars, but what I've tried to do is just condense what I thought would be some essential information, some things hopefully you'll be interested in. And I think really what we should try to aim to do is to sort of take as many questions as we can towards the end of the session regarding any of the content that we're talking about or anything else we haven't covered. So my name's Harry Jayaram. I'm a consultant at Moorfields and I work at the UCL Institute of Ophthalmology also. So the first thing that people often ask us is, what is glaucoma? And we've spent days and weeks at sort of consensus meetings with glaucoma specialists from across the UK, Europe, and the USA, trying to come to an agreement for a definition. And inevitably, you get to the end of the weekend, and it's very, very difficult. And it just goes to show what a complex condition it is when even specialists can't necessarily come up with a sub 20-word definition of a condition. In order to summarize it, I think that the salient points are that glaucoma is essentially a group of eye conditions where the common feature is damage to the optic nerve, i.e. the nerve that connects the eye to the brain, that can lead to gradual loss of vision. What's very interesting in terms of the consensus of the definitions is about the role of eye pressure. It's usually related to raised eye pressure, but not always. And in fact, the consensus definition that came out of these meetings didn't even mention eye pressure in the meeting. And so really there's characteristic patterns of damage to the field of vision and characteristic changes to the appearance of the optic nerve that lead us to make the diagnosis. The reason why eye pressure is so important is that currently eye pressure is the only modifiable risk factor that we know that we're able to treat based on evidence from numerous clinical trials over the past 2 to 3 decades. How does glaucoma develop? Now, this is just a very simplistic diagram to illustrate the point. Now, what we can see here is that the fluid that keeps the front of the eye intact, called the aqueous humor, is produced from behind the iris, the coloured part of the eye, and then it filters forward through the pupil, and then it drains away at this sort of junction between the cornea, the clear part, and the iris, what we call the drainage angle or drainage channels. So normally the flow of fluid is sort of from backwards to forward, and this enables the eye to maintain its structural integrity and also an intraocular pressure. Now, in simplistic terms, glaucoma is glaucoma due to high pressure is caused by a mismatch of how much fluid is produced and how much fluid we're able to filter away. So it's the simplest way to explain this. If you see where the red cross is, if there are some barriers to the efficiency of the eye in producing fluid, then the eye pressure can become uncontrolled and can become higher. Now, this may also be because we're producing too much fluid as well. So I like to think of it, it's a bit like an analogy with a bath. You've got the drains might be blocked, the plug might be sitting in a little bit, and also the taps might be producing a bit too much fluid. Now, the consequence of high pressure within the eyeball is that pressure can be transferred backwards. And this is to the right of this little schematic diagram is the optic nerve, which essentially connects all of the fibers within the retina back to the brain. Now, where the optic nerve leaves the eye, that's where these cells are particularly susceptible to pressure-induced damage. Now, we know from laboratory studies that the damage can be related to physical pressure, i.e. sort of squashing. It can be due to fluctuations in pressure, and it can also be to do with sort of shearing forces and movement and changes in the anatomy of the optic nerve. And there's a lot of research that's been going into that aspect of the disease. One of the things that's particularly alarming is, patients often ask, will I experience any symptoms? Now, for the vast majority of types of glaucoma, there are no symptoms at all. And peripheral vision loss can be quite subtle and very, very gradual. And that's why glaucoma is often talked about as the silent thief of sight. And I think this really emphasizes the importance of regular eye tests. So even just going to see your local optician every 1 to 2 years, especially if you have a family history, this can hopefully pick up things at a very early stage. The next question is really, people always want to know who's at risk of developing glaucoma. The reality is anybody is at risk of developing glaucoma. Within the research community, one of the sort of theories about glaucoma is in many ways it's sort of a form of accelerated aging. So we see changes at the back of the eye, the optic nerve, that can happen as we get older normally, but just as an accelerated rate. The major risk factor that we do know is age. So people that are over the age of 60 are at higher risk. We know that certain ethnicities are also at higher risk of developing glaucoma. We know that if you have a family history, so usually with a family history, we're talking about a first-degree relative. So that would be either a sibling or a parent that's affected. Also, if people are very short-sighted, so with a highly negative or myopic prescription, they are at greater risk of developing glaucoma. And if you have a very hyperopic or a strong plus prescription, you're at greater risk of developing what's called angle closure glaucoma. And glaucoma can also be associated with other medical conditions, other medicines. Like one of the commonest things that we always ask about are steroid medications. And now people may use, for example, they may have eczema on their face and they may use some steroid medications to treat that. So people may use nasal sprays for allergic rhinitis, which have steroid contents. And these can also cause people to have high pressure and develop glaucoma in the long term. So these are always things to be aware of. Now, in terms of, as a glaucoma specialist, I just want to talk about what our approach is when we see patients with glaucoma. What are we aiming to achieve? And I think, just to summarize things, the primary aim is to preserve people's vision so that they can live a full and normal life with as minimal impact as possible from glaucoma. We would also like to try to prevent and restrict further damage to the vision from glaucoma. And the reason for that is that because current technology doesn't allow us to restore any sight that has been lost. And the other very, very important thing, I think, is to minimize any risks and side effects of treatment. And that's why it's very important to only start treatment when there is a clear need to. And I know that in many community clinics, certainly when the patients are referred to a hospital setting, we do see a lot of over-treatment. And obviously, over-treatment has the major risk of causing side effects and problems from eye drops. So it's very important only to really think about offering treatment when it's appropriate and the correct thing to do. Now, in terms of treatments for glaucoma at the moment, I think we can summarize these into sort of two categories. We've got laser or eye drops, and we'll talk a little bit more about laser treatment, in particular selective laser trabeculoplasty shortly. And probably a whole separate webinar and talk would be about surgical interventions, which can range from perhaps stenting procedures to open up the drainage channels, what we call a trabeculectomy to to filter fluid away, and also the insertion of drainage tubes into the eye. So really that's a whole separate webinar that I'm sure we can plan in the future. Now, one of the major advances that has taken place within ophthalmology and glaucoma care over the past couple of years is a major research trial that was led at Moorfields by my colleague Professor Gazzard, called the LIGHT trial. And what this really showed was that SLT laser is an effective treatment for newly diagnosed glaucoma or ocular hypertension. Now, the great thing about the laser treatment is that it's very, very quick. It's performed in the outpatient clinic. It takes about 10 minutes or so, and it can also lower the pressure for several years without the need for any eye drops. It also has the advantage of we can repeat it up to 2 to 3 times if it's been successful. And I think one of the great advantages is it reduces the need for eye drops and therefore potential side effects, and also reduces the need for proceeding to surgical intervention. So although we enjoy operating, it's always great if we can not operate for our patients' sakes. So this is just a little summary of the LIGHT trial. So what they did was they had about 329 patients in each arm, and they were randomized to either drops or laser treatment. And I think the take-home message is that about 3/4 of the patients who had laser reached their target pressure and were medication-free at 3 years. And another interesting finding was that there were 5 times less medication-related side effects, adverse events, with patients who had the SLT laser compared to the other group who had conventional drop treatment. So this has really changed national policy within the UK and in many ways overseas also. So this really confirms that when we see patients who have newly diagnosed ocular hypertension or open angle glaucoma, we would normally discuss and offer SLT laser as a first-line treatment over and above eye drops. And obviously this is a very personal decision to make. Some people are very anxious about laser and may prefer to have drops, but it's great that we have this option, this option supported by very, very strong, robust evidence that can inform best practice. So eye drops for glaucoma. This is just a snapshot of what I could find in a cupboard, and this is the tip of the iceberg. And there's a whole host of eye drops out there. Some have preservatives, some don't have preservatives. Some have one medication, some have 2 medications within them. And just to sort of summarize, if I go back to my analogy about the bath, eye drops will work in either 2 ways. They will either turn off the tap, i.e. reduce the amount of fluid that the eye produces. And these are typically drugs like timolol or dorzolamide would work in that manner. Alternatively, they can work at the other end and they can open up the drain pipes a little bit, i.e. help the eye become a bit more efficient at filtering fluid out. And medications such as latanoprost and bimatoprost and travoprost work in that manner. So for the next section, I'm just sort of put up some questions that we're commonly asked. I'm sure I won't touch on everything, and that's if there are things that we haven't covered, please do put them in the Q&A, and we'll try to go through those in turn. One of the first things that people always ask is, what will happen to me? Because it's very likely that prior to coming to an eye clinic, you wouldn't have even thought about glaucoma or known anything about glaucoma. And so just to sort of summarize things for newly diagnosed patients, people would generally attend for their diagnostic tests, which would include measuring the vision, eye pressure, the field of vision, and usually an optic nerve scan, typically between 1 to 3 times a year. It's quite common to attend more frequently shortly after diagnosis, so that we can get a really good, reliable baseline of measures. Because all of the tests that we do, in particular the field of vision test, they're very variable. Everyone is human and people's function varies from visit to visit. So we have to try to work out what's normal fluctuation between human performance and what could be a change in performance due to the condition itself. And usually these tests will be reviewed by a glaucoma consultant and their team, who will advise you on treatment if needed and discuss further options with you. And as a rule of thumb, generally, as your condition becomes more stable, let's say you've had some laser or you've had some drops and you're showing stability on all of your tests, the frequency of clinic visits tends to reduce. And most people are seen once or twice a year once the condition is stable. Now, in terms of types of glaucoma, again, this is a whole 3 textbooks worth of discussion, really. We talked about at the beginning trying to define glaucoma, and really it characterizes this broad range of conditions that has characteristic optic nerve and visual field patterns of damage. Now, when in medical terms, when we talk about these being associated with other conditions, then we talk about secondary glaucomas. So for example, if somebody's had an eye injury, or if they have another condition such as something called pseudoexfoliation or pigment dispersion, or let's say they've had long-term steroid use for another medical condition, these can all cause high eye pressure and glaucoma, and these might be called secondary glaucomas. However, the vast majority of glaucomas do occur in isolation, and these are what we call primary glaucomas. So the commonest type in adults is what we would call primary open-angle glaucoma, and this is where, when we examine the eye, everything looks normal in terms of the drainage channels are open, but there are characteristic changes from glaucoma. We also, the other very common type of primary glaucoma is what we call primary angle closure glaucoma. And this is where we have narrower drainage angles and there is a barrier to the fluid filtering out. And that's the type of glaucoma that can have symptoms if it presents with very, very high pressure. So really, I think the majority of glaucomas that we see in our clinics are primary in nature. And this is a very individual thing. So it's always, when you first see your doctor or your first diagnosis, it's always important just to ask what type of glaucoma you have. In essence, the treatments will be very, very similar, all aimed at lowering the pressure, but there are slight nuances between the conditions about for example, what sorts of laser treatment or surgical treatments may be more appropriate if needed. Another thing that people often ask is, I'm very young, how come I have glaucoma? Now, this graph really just shows how glaucoma the prevalence does increase with age. Certain ethnicities are at much greater risk. So the prevalence of glaucoma in, let's say, African populations and Caribbean populations are much, much higher. When I started my ophthalmology training, I worked in South London and worked at St Thomas's Hospital. And what first really shocked me was the typical age of presentation with patients with quite advanced glaucoma. So we would see people in their 30s, early 40s with very, very severe glaucoma with very little visual field remaining. This really does emphasize the ethnic variations in the condition. We mentioned earlier it's much more common as we get older, but this glaucoma can occur in younger people and also in children as well. Now, in terms of the genetic risks, there are at the moment over 150 genes that have been linked to glaucoma, and we do know that if you have a parent or sibling affected, you are at greater risk. And there's lots of research going on into potential genetic studies and trying to understand what genes may be associated with glaucoma risk and also the severity of glaucoma as people get older. There's a link that I'll just discuss with you at the end about research at Moorfields. If you wanted to get involved with some studies like this, these are things that we're running at the moment. A very, very common question is, will I go blind from glaucoma? And I think, in honesty, for the majority of the patients that we see, the answer is no. Blindness from glaucoma does occur, but it is rare. And I think we're lucky in the UK that we have quite early detection, very good community screening that helps prevent late presentations. The other thing is, with the help of Glaucoma UK and patient charities, there's a lot more, and events like this, we hope to improve knowledge and understanding of patients and their families with glaucoma. And I think really when we understand things better, we understand why treatment's important, and therefore we use the treatment. So I think improved patient knowledge and education with the help of our partner charities really helps with this. And I think the other really important thing is making sure that you attend your follow-ups and work together with your glaucoma team to make sure your treatment's working. At Moorfields, we have a rolling non-attendance rate of about 20%, which if you think about this, that's one in 5 patients who have an appointment don't turn up. And they are the patients we really worry about, because we don't know what's happening to them. If we can't get in touch with them and they don't come to their appointments, these patients are at risk of losing sight. Another common question that we're often asked is the relationship between glaucoma and blood pressure. Now, again, for most patients, I think the answer is no. However, what we do know is that in certain types of glaucoma, where you have low blood pressure, this can actually, at certain times of day, reduce the blood flow to the optic nerve, which can actually worsen the glaucoma in some cases. Now, this is particularly relevant in normal tension glaucoma. So this is where normal tension glaucoma is where you have characteristic changes in the optic nerve appearance and the field of vision, but the pressure might not be particularly high. So you can typically, you could have an eye pressure of 12, 13, for example, yet still have problems with glaucoma. Now, one of the problems is that if certain drops that we give people, for example, a beta blocker, if people have a beta blocker in the evening, this could get absorbed into their bloodstream, lower the blood pressure overnight, and actually you could get into this situation where you have low blood pressure, i.e. low perfusion of the optic nerve, and relatively high eye pressure overnight, which can actually cause damage to the optic nerve and worsen glaucoma. And that's why we're quite careful with patients who have normal tension glaucoma. We're quite careful about what drops are given when, to try to reduce the risk of what we call nocturnal dips in blood pressure. And sometimes for patients with normal tension glaucoma, before, just at the initial assessment, we may even ask local GP to organise 24-hour blood pressure monitoring to look for evidence of dips in pressure. We showed that we talked about eye drops and how, I know that eye drops are the bane of people's lives, and typically people say to us, I had no symptoms from my glaucoma until you gave me eye drops. Eye drops are effective, but over time, people can develop reactions to them, and people can also develop reactions to the preservatives. And it's a common problem that we face with many of our patients. I think the first thing to ask it, to try to work out is this actually a genuine allergy to the active ingredient of the eye drop, or is this just a reaction to the preservatives that are within the drop? That's the first thing to ask. Now, sometimes what we do is what's called a drop holiday. So if somebody's using 2 or 3 eye drops and the eyes are sort of red and the ocular surface is irritated, the first thing to do is stop everything. Now, that can be quite alarming to start with, but actually what we tend to do is, it's quite safe to do that for a 3 to 4 week period. Usually we would give maybe a small tablet or half a tablet of something called Diamox or acetazolamide, just to bring the pressure down a little bit. And sometimes we actually give a very, very, very gentle anti-inflammatory treatment to try and calm down the surface of the eyes. But all of the symptoms are really related to irritation of the surface of the eye from the drops or preservatives. After this sort of brief drop holiday, then it's quite a good idea to slowly reintroduce drops very carefully, perhaps more, certainly preservative free, and certainly some of the more gentle ones that we know, to see how those are tolerated. Another important thing to do is really to speak with your glaucoma specialist to find out whether selective laser trabeculoplasty is an appropriate treatment. Now, SLT, when we talked about the light trial, we talked about it as an initial treatment, but we quite often use SLT laser during regular clinical practice to reduce the need for medications. So, for example, if we have somebody who's using 2 medications to control their pressure, using SLT may well reduce the need for having 2 medications to having 1 medication, which is a great thing, because the fewer number of drops you're having to put into your eyes, the better. So definitely I would speak to your specialist about whether SLT is an option. The other thing that may be relevant, depending on how old you are and whether you have any presence of cataract in either eye, one of the things that we're commonly doing now with all of our patients who have glaucoma, who are having cataract surgery, is to use, there are various what we call trabecular bypass stents. So you may have heard about something called the iStent or Hydrus microstent. And what these do is these help stent open the drainage channels. They take about 5 minutes at the end of cataract surgery. This may be another option. If you have cataract present, cataract surgery with a stent can quite often lower the eye pressure by 4 to 5 millimeters for several years. So that's, again, something to discuss with your specialist. I just want to talk about COVID very briefly and glaucoma care and how it has changed and how it will change moving forward. Now, some of you may have experienced this before and after, but I think it's really important to explain why these changes are happening, why they're important, and why it's really one of the only ways that we can continue to provide glaucoma care within the NHS in a sustainable manner. So prior to the pandemic, certainly at Moorfields, 80% of visits were what we called a face-to-face clinic. And now this could involve anywhere from 2 to 5 hours sitting in a hospital setting. You'd have various tests performed. You'd see a nurse, you'd see a technician, you'd see a doctor, you'd go out and have your pupils dilated. You'd be stuck in a packed waiting room. And, these were renowned for being busy and overbooked. And obviously during the pandemic, this was something that we couldn't, it just didn't fit with social distancing and people's expectations. So we were forced to sort of rip up how we were doing things and redesign our entire services. So, we published this article shortly after lockdown, and it just sort of had a few reflections on what was going to happen, because we could see even at that stage that the impact of COVID-19 was going to really redefine how we delivered glaucoma care to our patients. I think there are 3 major principles that came out of this. The primary one was maintaining safety and welfare of patients and staff. Now, after the Prime Minister's announcement that, we can sort of all forget about COVID and carry on, I don't think that's not going to happen in a hospital setting for the foreseeable future. We're acutely aware of new variants, impact on vulnerable patients and staff. And, I think social distancing of hospital-based settings will continue for the foreseeable future, as it is continuing for testing of pre-surgical patients. So this first point is going to be very important for us. The second thing we really want to do is, going back to those busy packed waiting rooms, we want to minimize the amount of time that patients spend hanging around in a hospital environment. It's not, we all know and all knew back then that, it wasn't efficient and wasn't appropriate to sit around for 4 hours in a clinic where where in reality, the tests that you need only took about, half an hour, 40 minutes. So we're trying to be more sensible with patients' time, because time is valuable, and minimizing the amount of time that people have to spend in a hospital environment, because we know people are anxious about that. And then the third principle is really to make sure that we can efficiently look after all the patients who need glaucoma care with the level of intensity of care that's appropriate to their condition and the severity of their condition. So the main change that people will see over the coming years are what we call diagnostic clinics and diagnostic hubs. So the majority of patients with glaucoma moving forward will be seen in what's called a diagnostic clinic. Now, I'll just, next slide, I'll just briefly explain what a diagnostic clinic involves. Prior to the pandemic, like I said, we had about 80% of patients in our face-to-face clinics. During the pandemic, everything was deferred, and it was a few telephone consults, emergencies only. In the response to the pandemic and sort of moving up to now, we're seeing about 50% of our patients in what we call diagnostic clinics or in diagnostic hubs. Now, these are basically where you'll come in, you'll have all of your usual tests done. So you'll have your vision, your pressures, your visual fields, your OCTs, everything is captured. You will be in and out, usually in about 40 minutes rather than 4 hours. The information, the data is then reviewed in the context of your previous records by the consultant-led team. Usually we're trying to do this within a week at the moment. Now, if you have any specific concerns, or if there are any changes to your treatment or anything else that needs further discussion, we would normally then have a telephone consultation with the consultant to discuss anything and answer any questions at that stage. If there is a need for surgery or a need to be seen in a face-to-face clinic, then that can be organised also. And this sort of leads on to what's been happening on a research side as well. So we talked about trying to minimise the need of using hospital estates. So we were fortunate during lockdown, we were trying to work out what on earth to do, because at Moorfields we cancelled 40,000 glaucoma appointments in March 2020. And we've been chasing our tails ever since, trying to work out how on earth are we going to see people. So we were lucky to be awarded quite a significant research grant from the NIHR to set up what's called a reconfigurable diagnostic hub at Brent Cross Shopping Centre. So this turned out to be a retail unit. It used to be the New Look store. And we were fortunately able to get this rent-free for a period of time. And we basically turned this into a state-of-the-art diagnostic clinic. And essentially, we were able to see a huge number of our Moorfields patients who had been cancelled and deferred and needed to be seen. So that really filled the sort of clinical need. But more importantly, we're trying, this is really set up as a research project to try and work out what's the most efficient and patient-centered way to see patients, to see patients with chronic eye disease. So this was covering glaucoma and medical retina patients. And it was really it's been quite an exciting time. It's a hugely collaborative project. So we're working with the hospital, the UCL Institute of Ophthalmology. We're working with some of the leading healthcare architects in the UK from the UCL Bartlett School of Architecture. We're working with the Department of Applied Health Research at UCL, who are experts in health economics outcomes and patient-reported outcomes and development of new services. And we've been really helped by partners from industry in getting all this. It really is sort of state-of-the-art kit that we have in there at the moment. And the main questions that we're trying to understand from this project are, what are patients' preferences who use this system? What are their preferences about rapid diagnostic hubs for people with stable and chronic eye conditions? What are the factors that influence implementation and delivery in these sorts of hubs? And what's the effects of different models and forms on the delivery of care and patient outcomes? So one of the things that we're doing is, over a 9-month period, we're essentially every 3 months, we're knocking it down and redesigning it with a different layout to try and work out what's the most efficient way and the most patient-friendly way of running these clinics. And really, I think the question for the NHS is do rapid diagnostic hubs deliver cost-effective and value-based healthcare? And this is a sort of a bigger question that our health economics and strategic partners will help us answer. But diagnostic hubs really are here to stay for the future, because without these, the NHS care for glaucoma and chronic eye disease would just not be sustainable. Now, just to finish off, in terms of research ideas, we talked about pressure being the only modifiable risk factor. Now, there's always been a lot of interest in complementary therapies to treat glaucoma. There are lots of supplements that are available that have some modest evidence, but really haven't been studied in robust clinical trials. And one of the concepts is what we call neuroprotection and trying to protect the optic nerve. Now, one of my colleagues in Australia did some work using vitamin B3 called nicotinamide, and showed that there was some potential for sort of recovery of function in patients who had glaucoma and high eye pressure. And this proposal has been put through to the NIHR over the last year or so, and there's a larger clinical trial that's due to start later this year at Moorfields to try and answer this question. And I think what the researchers are planning to do is to randomize patients to standard treatment that they may be on anyway, and also this additional supplement to see how this might help, in particular, slow down any changes in visual fields progression. So this is a study that's going to be starting later this year at Moorfields. We talked about cataract surgery earlier, and what's interesting is 2/3 of patients diagnosed with glaucoma end up having cataract surgery within the first 6 years after diagnosis. We know that cataract surgery gives roughly a 5 millimeter reduction in pressure for about 5 years. So one of the things that we're discussing with our cataract surgical colleague is the possibility of designing a clinical trial where early cataract surgery may be an intervention to newly diagnosed glaucoma patients, which hopefully may delay the need for anything more interventional. But this is still in development at the moment. Now, this is a project that we've been developing at Moorfields over the last year or two, and it's essentially a patient portal for patients and their carers or anyone who's interested in eye research to get involved. So the website here is, if you just put in research.moorfields.nhs.uk, you can sign up to this, even whether you're a patient at Moorfields or not. And it gives you the option for sort of disease-specific conditions, whether you want to take part in focus groups or actually in clinical studies themselves. And so for example, let's say you were interested in the nicotinamide study later in the year. If you were to sign up on the website, that would enable that when they are screening for recruitment, they'll be able to get in touch with you. So please have a look at this, and we are encouraging everyone to sign up if at all possible. So finally, before we get on to our 34 questions, glaucoma, once it's diagnosed, can be treated. So please be reassured. Blindness can occur in glaucoma in the UK, but it is very rare. And glaucoma monitoring in the post-COVID era will be very different. It will be a different experience, but the reason for that is to make sure that we can continue to look after all of our patients for the next generation. And also, research into glaucoma is an exciting area which you can contribute, get involved with, and help shape. So please do sign up to the research.moorfields.nhs.uk. Thank you. So Mel, over to you, and then we'll start fending the questions.
Hi, that was really interesting, Harry. Yeah, there's one just come off the back of that. Somebody's asking, where are the diagnostic hubs? Are they just in London?
No, so what's interesting about diagnostic, the concept of diagnostic hubs was a national government diagnostic, Department of Health strategy. So they're all over they have got them all over the country. Bristol have some very advanced hubs. The Midlands have several hubs set up. I think Wales have got 1 or 2 set up. They're generally on the whole, they're being used for multi-specialty use. So it's not just ophthalmology. So anything that can be done in a building that doesn't have to be in a hospital is suitable. So typically lots of sort of imaging based specialties. If you need to have ultrasounds or one-stop clinics for dermatology or lumps and bumps and things like that. And one of the things that they're trying to work towards is, let's say, even for cancer treatments, a one-stop diagnosis treatment where you can come in, have your imaging and a biopsy, that would happen as well. Within ophthalmology, the other thing that's at the moment, certainly post-COVID, the diagnostic hubs have been really prioritized for glaucoma and retina care for patients that need, quite essentially imaging-based diagnostics. But one of the things that we're trying to move towards is actually for cataract surgery, having a cataract one-stop clinic almost. So you could come in, see a doctor, have all your measurements done for cataract surgery, have all your, everything that needs to be done, your pre-assessment, so your next visit is for surgery alone. Because at the moment we're very inefficient, because for cataract surgery you'll come into a clinic, you'll see somebody, then you'll go home, then you'll come back for a pre-assessment. So they're just trying to be efficient with patients' time and hospital estates.
Okay, we've got another question here. Can an irregular heartbeat cause normal tension glaucoma?
That is not something I've ever heard about.
Okay, right. There's no one here. I have glaucoma as well as my father and my brother. Is it likely that my 4-month-old daughter will get it?
So I think that's quite a strong family history. So you've got, there's father, so that's one first
and brother, the mum,
and the mum. So yeah. I would, in that sort of case, yes, there's a significant chance that at some point in their lifetime, your children ought to be screened and are at risk from that. So normally what we would say is the NHS screening that's free screening is normally above the age of 40 for formal glaucoma screening. But I think so long as your daughter has regular checkups, I think the likelihood of I don't think there's anything to worry about under the age of 20. Congenital glaucoma or glaucoma in children is a very different condition that presents at birth. So you're talking about a familial, I'm presuming open angle or certainly a primary glaucoma. But yes, your daughter is at risk, but I don't think you need to worry about it for the first 25 years of her life. But just to make sure that she's seen by an optician every 1 to 2 years when she's older.
Yeah, so getting a check regularly will show
absolutely.
anything up. Yeah,
absolutely.
Okay.
And then if your daughter's lucky, she wouldn't have, wouldn't have your. I can't tell if that's the mum or the dad that's asking the question, but I
think it's the mother.
It's the mum. So may have inherited the other parent's genes.
Okay. Another one here for you. Does sleeping at a 45-degree angle help to reduce pressure peaks at night?
So I have got 1 or 2 patients who are quite, they've done a lot of homework and they are convinced that pressure of the eye on the pillow might make things better for them. And so what they've decided to do is, get some special goggles so that if they are lying, they don't sort of squash their head into the pillow. I don't know the answer to that. And I'm always one to sort of say, I'd like to sort of not let things dominate your lives too much.
Right. But do what's good for you.
Do what's good for you. I mean, if you're happy, if you're confident and you feel better doing that, then that's fine. But I wouldn't normally recommend that sort of practice.
Okay.
But I can totally understand why people might think that.
Yeah.
Mel, in some ways, it's the other thing that people sort of will often ask us about is yoga poses. If you're doing a downward dog, is that a bad thing? We know that doing a downward dog pose will probably cause a transient rise in intraocular pressure. The reality is that going to affect your glaucoma? We don't know. But then if you're doing other things for your general well-being, the benefits of yoga and relaxation techniques on your general health would probably outweigh the risks of it causing harm from that transient rise in eye pressure.
Just don't stay in a handstand for too long.
Yeah, don't sleep in that position, definitely.
Can I take hay fever tablets with my eye drops?
Hay fever tablet, yeah, there's no contraindication to that at all, no.
Okay. And somebody says, can you explain cupping? I don't know what that is.
Okay, so what people, when people talk about cupping, I want you to imagine you've got a donut. from Krispy Kreme, and you've got there's a little hole in the middle, and there's the thick, chunky donut that we like to eat. When we talk about cupping, it's essentially when we look at the back of it, and this is a sort of descriptive term, when we look at the optic nerve. So what we tend to see over time is that the hole in the middle of the donut gets bigger. Now, the reason we see that is because there's a loss of tissue. So it's not because someone's like, if you ate a bit of the donut, then the hole in the middle would get bigger. In glaucoma, the reason we see what we call cupping is the hole in the middle of the donut gets bigger because the juicy bit of the donut is the nerve tissue, and that's been damaged from eye pressure. And as the cells die away, that tissue disappears. So essentially, it's loss of tissue causes this sort of enlarged hole in the donuts, and that's probably the best way to explain cupping.
Okay, and somebody's asking, can they have laser treatment after having eye drops for many years?
Yeah, absolutely. You absolutely can do that. What we tend to find is, depends on how many drops you're using, but it's something that we quite often will advise, especially our more older patients who might be in their 80s and they're struggling with multiple drop bottles. The SLT laser is very safe. The main risk, I always tell patients, is that it may not be effective. So in many ways, there's nothing to lose in that respect. There has been some thinking in the past that if you've been on a prostaglandin or latanoprost for some time, then SLT may not be as effective. But I'm not aware of any robust evidence to stop, to prevent that treatment. I would still recommend a trial of that, because if it means that we can get someone from using 2 bottles of drops to 1 bottle of drops, I think that's a huge difference. And certainly reduce, if we can eliminate a drop that's potentially causing side effects, I think it's certainly worth a trial.
Okay, another one, medication. Somebody's saying, can you take Lemsip cold and flu tablets with primary open angle glaucoma? Because it says on the paperwork you can't take it with closed angle glaucoma. So
generally, any sort of contraindication to closed angle glaucoma, it normally means that the drug might dilate the pupil a little bit. So for Lemsip cold and flu, they normally have a bit of epinephrine in, which is like adrenaline. So in theory, there's a theoretical risk that the pupil may dilate slightly. So what they're covering themselves with is, if you've got narrow angles or occludable angles or closed angle glaucoma, it's probably best for you not to take that. For any other type of glaucoma, it's absolutely fine. Personally, I think even if you've got closed angle glaucoma and you've got a really bad flu-like symptoms, I think a dose of it would be fine. So I think you're talking about the risk they're talking about is pupil dilation, which is very subtle.
Okay, and do you think there's any indication that stress can play a role in glaucoma?
I don't know, but this is one of these things that's very difficult to quantify. I do think that we underestimate the effect of stress on all medical conditions. So I don't think anyone could confidently exclude that. There's some very interesting work that's been done in India, where they looked at the impact of mindfulness meditation on pressure control. And also they looked at the effect of mindfulness meditation on expression of various genes within the drainage pathways. And it was pretty smart research, and it was quite controversial because it was it's a little bit out there. It's sort of, and they were basically advocating that regular medication can help get the pressure down a little bit. And I think I was one of the reviewers for the manuscript when it was published, and I do think there is evidence there to show that this sort of relaxation techniques can help. And it's interesting that during COVID, with the advent of everything being by Zoom, that was something we were planning to try and set up. I think I might sort of get some of our fellows to sort of resurrect this, but it would be quite interesting to have over Zoom, just some mindfulness meditation sessions and try and study the impact on eye pressure. So on that note, I do think never underestimate stress.
Yeah. Yeah, it plays a role in everything.
I think so, yeah.
Yeah. Somebody's saying here, their doctor wants to do a trab on one eye. They also have small cataracts. Should you have the cataract surgery before rather than after the trab?
So I think when we have this sort of discussion with patients, the important thing is, what's the primary problem that is going on? Is it glaucoma that's getting worse, or is it the fact that vision's affected by cataract? If the glaucoma is clearly deteriorating, then we would always do the trabeculectomy first, because we want to try to prevent loss of vision. If the glaucoma is fairly stable, then and if someone is symptomatic from the cataract, you could do the cataract first. I suspect that if the doctor has already talked about trabeculectomy surgery, I suspect that the glaucoma is the primary problem, and that ought to be addressed first.
Okay, I think we've just got time. One more question. Should we start to take vitamin B3 as a preventative measure?
Well, I don't know the answer to that at the moment. That's hopefully what this clinical trial will answer. You can buy this over the counter, and the dosage is normally it's about 1.5 grams in split doses throughout the day. So the guy who did the preliminary work is a friend of mine, Professor Jonathan Croston, he's in Singapore at the moment, and I know that he took it for a few years after. It's one of these things because it's a natural supplement. What we're hoping that the trial will show is there a benefit for patients in glaucoma in reducing risk of progression, but whether you should take it as a preventive thing, I don't know. The main side effect, so if anyone does decide to go and buy some, the main you can get it from Holland and Barrett over the counter, but the main side effect is tummy upset. So that's
okay. Right. Okay. Thank you ever so much for that. I go back to my slides. Can you see that? Do you have my slides? Right. So thank you to everybody for joining us today. I hope you found it useful. So there's the details here for contacting our helpline. Our number is 01233 648170, and our email is helpline@glaucoma.uk. So if we haven't been able to answer your questions today, our helpline staff will be more than happy to help, or contact them with any other questions you may have about glaucoma. Now, I'm going to launch the second poll. I don't know what happened with the first one. I don't know if it worked or not, so it will be on your screen for a little while. Oh yes, looks like people are able to answer this one, which is fantastic. I'll leave that up for a few more minutes. So thank you again to our speaker Harry for it was a fantastic talk and well-fielded questions, and thanks to my colleagues Joe and Tom for their support. I'll leave the poll just for a few more minutes. I just let you know that our next webinar is on March the 7th at 7 o'clock, and it's about glaucoma surgeries. And if you'd consider completing the survey, which we're going to launch at the end of this webinar, because we want these sessions to be great. So the more feedback we receive, the better the sessions we will going to provide. So I'm going to end the poll now. I think everybody's answered. So thank you very much, everybody, and have a good evening.